On-the-scene coverage of ACC 2015 is supported by Effient.
I'm Peter Block here in San Diego at ACC 2015 for On the Scene, and with me is Pam Douglas. Pam is an old friend from Boston, now at Duke, and we have known each other for a long time, haven't we, Pam? Pam is a PROMIS person, and you've all heard a lot about PROMIS already. It's been talked about a lot here at ACC 2015. Pam, PROMIS is a complex trial, and there are 1,000 different interpretations, so you get to tell me yours.
My interpretation, when I designed the trial, we wanted to learn about this area. So my interpretation is that we have learned a lot and that we have a lot more to learn. Now, what have we learned specifically? That CT should take its place alongside the other modalities. It does not offer superior outcomes. We see that in this relatively low-risk group. But what it does is provide a better triage to the cath lab and potentially lower radiation if your choice is nuclear testing.
So that was really the thing that struck me most when I looked at these data, and that is that the radiation dose from the CT guys have gotten pretty good at lowering radiation, and therefore we can do that without having to worry about the radiation dose. Tell me what you think about a negative CTA. Does that help you a lot in your evaluation of patients?
I think it does. I think it tells you that that person is not at risk for an event. But what it doesn't tell you is that that person doesn't need primary prevention. And so we want to be careful that we don't say, well, no plaque, stop the statin, stop the aspirin. These patients had a serious risk factor burden, and we want to make sure that we continue to treat those risk factors because that's proven treatment.
There you go. And the other thing that I need to ask you is, well, okay, some people are looking at these data and saying, oh, well, this is simple. Everybody needs to have a CTA, and that's the way to evaluate anyone who even has a whisper of chest pain. Would you agree with that?
No, I wouldn't agree with that.
Nor would I. I'm not surprised. But nevertheless, I think it's important to point out that that would be a foolish assumption from these data. Would you agree?
I agree. You know, we are lucky enough to have a range of non-invasive tests, and CT now becomes one of those. But picking the right test for the patient in the setting in which the test can be done well and safely is more important than saying this test A or test B.
Also, in sort of the backroom discussions we've had about this, a lot of people have said, well, you know, it depends a lot on where you are, what kind of expertise is around you.
I would absolutely agree with that. I would also emphasize for those people that say, you know, this proves that we don't need to test at all. We achieved a very low event rate in this trial in both arms with the use of testing. So we don't know if we'd have that same low event rate if we didn't test.
All right, so there you have it from the horse's mouth. The lady that actually designed this trial, PROMIS, probably is best interpreted as saying we have a lot of tests that are available to us. CTA now joins it at a low radiation dose, which is a good thing, but certainly not that CTA should be used for everyone. Fair enough, Pam?
Fair enough.